to introduce the next speaker, let me make you all uncomfortable. If you had to choose an excellent surgeon, yeah, you need a pacemaker, let's say, a medical device. I don't know, is it a high-risk medical device? Good. Would it fall under the category? You have an excellent surgeon and a mediocre device. Or you have a mediocre surgeon but the best device. Which one would you go for? Personal, for yourself. So the excellent device or the excellent surgeon? Let's vote. Excellent surgeon. Excellent device. Interesting. Very interesting. Okay, the next speaker is an excellent surgeon and he only uses excellent devices. And we know it because he's a professor of orthopedic surgery at the University of Leiden in Netherlands. His doctor thesis in 1995 was called, I need to read it up because I think this was very interesting. His doctor thesis is called Fundamental Aspects of the Clinical Evaluation of Total Joint Prosthesis. So in the end, he started out 30 years ago with exactly the same question he probably is answering today for us. He has an excellent history as an orthopedic surgeon. He's founded and supporting the third largest world register in hips and in arthroplasty, I think, total arthroplasty. He's a long-term member of expert panels, so exactly the person for us to educate us about the work of the expert panels. Thanks for being with us, Rob.
And Elaine, of course, as well. The only thing is I'm not in control because you have the mouse. That's the only thing. Well, that's fine. I have this associative memory working presentation. So, well, yes, we have. I believe in data-driven healthcare. That's all my residents in my department are just marinated in the essence of you need data to treat your patients. You need data to have the best available implant which you are going to implant. You need evidence to do surgery or not. The interesting thing is, however, I know how many doctors are in the room? Well, you know, as a doctor, you know, when you still see patients, you know, it's not always about data-driven healthcare, especially nowadays. I mean, it's the idiocy, to put it very bluntly, about the social media. People believe in a certain, I fully believe in prompts. I did prompts research for 20 years, but there's also, pages have opinions based on advertisements, social media, and they think they have the perception they have increase of their, reduce of their pain. That's very interesting. Anyway, that will not be a philosophical talk. Next slide. So I put this on. Why did I put it on? We do a lot of research in the academia, and the academia, the university doesn't pay anything of the research. It has to be through funding. So it's the national healthcare, EU, and also industry. But I'm the investigator. I'm not being paid by the industry, but we need money from the industry to do the research for all the PhD students I have. I will deliver about, I think, 75 PhD students, and at the moment we still have 10 left. Well, I'm the founder of the Dutch Arthroplasty Registry, indeed. That's very important. And I'm also in the board of EFORT, the European Federation for Orthopaedics and Trauma. And of course, the reason why I'm invited, I think, was also being the chair of the thematic panel. And a member of the CIE group of the Medical Device Coordinating Group in Brussels, all in my free time. The question about the 60 days, minus 21 days to Andreas, when we do not deliver within the 60 days, we are not being paid. Since I'm the chair, I'm being paid for 2 days, and I get 450 euros a day. In the Netherlands, we pay 52% tax, so it's 220 euros net. So I do this because I want to improve the world. So that's the question. So I want to improve. I'm very Europhilic. My American friends always tell, hey, what do you mean, Rob? I'm Europhilic. We decide what you have to do. You are just the third world country across the ocean. That's the one when I'm in the US. Anyway, that's perhaps my big bias. Next slide. So what were you talking about? Most of these things are orthopedic implants. Here's a pacemaker, the stent, and up there's this leaking breast, this breast implant, which invoked actually the MDR, the MDR in 2017, I think, and also the metal-metal, the things we did in orthopedics, we also not ideal. Metal-metal implants, a big disaster, and of course the vaginal meshes, and of course software. That was, I think, these 4 things were the reason to implement the MDR. Next slide. And when you have these slides we have patients. I'm a doctor. I'm not a surgeon. I see more patients than I do surgeries. But the patients, when they have an implant, next slide, when they get an implant, they expect that the decisions I make, next slide, it's based on evidence. And of course, next slide, the surgical skills. And I think they will have more benefit. For patients, it's very difficult to grasp that they can have an infection. We have a total hip, total knee, total elbow, all these implants we have. That's the 1% likelihood for infection. But that's a very vague, abstract entity. The patient who has an infection, he or she knows what an infection is. So ask the patient before what he or she thinks. I think it's very, I'm not arrogant, I'm not paternalistic, I'm Dutch, so we have a very flat society. But the most important question, I think, we know implementing this now in Dutch arthroplasty is, what is the expectation of the patient of the outcome? And that's also very vague. But then you have to list 1, 2, 3, and ask them again on 6 months and 1 year, are these 1, 2, 3 before surgery or before your treatment, before your osteoarthritis treatment, are they implemented? And then on a 0 to 4 Likert scale, but that's research again. So that's my answer to prompts. Because at 2 years, your pain of your knee may be caused not due to the fact you had a bad knee, your total knee, but because you have pain in your shoulder, or you have pain in your back, which influence your prom. Anyway, read all the articles we read about this. That's, again, next slide. That's the topic. But sometimes, instead of benefit, we have risk. I also have complications. That's very sad. There's a tile on the wall in my department. Even I have complications. That's a big tile because I said that's, I think, 25 years ago. They put a tile on the wall. And we do not like this to have the risk. Next slide. And that's the reason we have the MDR, leaking breast, etc. Next slide. The good thing about the MDR, I'm really believing in MDR. That's, of course, perhaps a little baby is growing and growing. The good thing is, in the past, we had silos. Manufacturer silo, regulator silo, EU level, national level, and we had notified bodies. The good thing is, next slide, at least now we have clinicians involved, the expert panels. That's a good thing. I have the opinion that I know, I have the Holy Grail, I know what I'm talking about. And I have a scientific background. That's the reason I like this science-oriented physician. When we had the first meeting in ISPRA, I remember in 2019, April, I was there with Alan Fraser, 4 people, and the Joint Research Council in ISPRA. I said, what we need on the expert panels, mandatory methodological trained or epidemiological trained physicians. That was not possible, because I even see, I'm now, did for the last 4 years things, there's some gap, some uncertainty. Next slide. Usually as a surgeon, when I indicate physiotherapy, surgery, or medication, I look at this patient and see, hey, there's high risk for surgery, so I go for physiotherapy, or perhaps medication for osteoarthritis. And when you have a bone tumor patient, my department is the biggest in bone tumor in the Netherlands, then when you have a 15-year-old patient or a 19-year-old patient that's bone tumors, then we accept high risk, but not in elective knee, hip, shoulder, etc. surgery. So, but I also know I will have some complications. And hopefully is that reduced. It will never be 0. A surgeon who says I have a 0% infection, he or she never does surgery. Don't believe him or her. He's lying by definition. Next slide. The manufacturer, oh, that's fine, that's fine. You can go back. The manufacturer has, of course, they also look at the predictable profit, which makes sense. Of course, they have to make profit. I'm not a socialist. That makes sense. And of course, they're also risk-based, because they do not want to have a bad product on the market, because they're not sued, etc. And so they have a different opinion than I, as a surgeon and clinician and scientist. And I claim to be a scientific-based orthopedic surgeon, and I do different things than the guys and women in private practice in the Netherlands. It's not arrogant, but that's how it is. Just get real. That's my point to you. The regulators, they were very risk-averse. They do not accept risk. When I walk out of this room, I gave a workshop with the EMA in Brussels at the MDCG in Brussels, and I pointed up to the Dutch regulator. When you spilled coffee on the floor, I walk out and fracture my hip. It's your fault. And shit happens. And that's very difficult for regulators to accept. And we live in a real world, and that happens. Do in the next slide. The good thing is about the MDR, that these, next slide. The good thing is that all these 4 silos are no more aligned. And there's this cross connection, I think. Next slide. That's the role of the expert panels. I would like to take you along. Next slide. So we give opinions, and we give also opinions to the next slide, to notified bodies, manufacturers, and also within the MDCG. I happen to be, I would have thought you, a member of the CIE MDCG group as independent expert or observer. Next slide. And then when you have these implants, next slide. Well, in the law, in the MDR regulations, it states clinical evidence. For me as a surgeon, this is clinical evidence. More benefit than risk. Is it rocket science? No. Well, the only thing is it moved a little. But anyway, it's more than one. This is the text. Well, it's very complicated. And when you have Article 61, conformity shall be confirmed on the basis of sufficient clinical evidence. I remember when I met with Paul Piscoy, it was in, I still remember it was because it was I think it was in March 2021, because we still have this COVID thing. So I was not allowed to do surgeries, only the bone tumor guys on my department were doing the surgery. So for, I think, a whole day, Paul and I was on Zoom in Leiden, Paul in Brussels, Amy Smithwaite from the UK was there, and we just talked the whole morning on some sentence in this guidance document from the MDCG. I think, come on, guys. And there was, of course, people from the industry, Basile Accra, he is, well, from TÜV Süd. He's a very political animal. I was also very surprising. I was allowed in a closed meeting because I was independent. Then the notified bodies had to move out, the industry had to move out. That's also to see how these things are working in Brussels, I think. But anyway, talking for just wording. And the industry is actually, they have to justify why there is clinical evidence. Next slide. Important thing to know is that medical devices, and that's also, I gave a workshop at the EMA as well, they're fantastic in the European Medicines Agency for Medicines, but they had to learn on medical devices. I gave a workshop in Leiden, because the EMA is only 50 minutes by train from Amsterdam to Leiden, so it's easy for me. I gave them a workshop in September with the whole team was there, was fantastic. In orthopedics and with devices, we seldom do a phased approach. Ideal, next slide. I'm really a believer in this. You have an idea, you should do your development, exploration, assessment, long-term follow-up. That's the ideal way of dealing with new devices. That's supported by the Oxford group, Peter McCullough. I support this, Arthur Drake in the US. But is it mandatory? I think at least when you have something new, you should just do follow-up. That's a go, data-driven healthcare. Safety and performance is supposedly more important than efficacy of that implant. It's very difficult to measure because in psychology on the patient level, it's very difficult. And the device, a hip, knee, shoulder, there's some small iterations which may cause a big problem. No, but that's possible. And equivalence, and that the last thing important, your question, Jörg, a surgeon, you have handy surgeons and non-handy surgeons, and by the end you need at least the almost excellent surgeon and the almost excellent device. And we have registries around, and the surgeon can pick the best performing implant from that registry. So it's a no-brainer for me that a surgeon uses a mediocre implant with a 10% loosening at 10 years, while the implants are around which have 2% loosening at 10 years. That is, nowadays, that's I think is even fraud, should be a criminal act. I'm very upfront now. But there are new devices, and they should be put in this ideal thing. Do a measurement with 3D with stereo photogrammetric analysis. Means you can measure migration up to 0.1 millimeter. That's possible. Next slide. So the reason I think, so that's the reason the pyramid which is used in evidence, clinical evidence-based medicine is slightly different in orthopedics. But this is a good thing. There are many big registries around. In the Netherlands, we have 1.3 million implants in, 99% complete for primary and secondary, hips, knees, shoulder, elbow, wrist, hand, ankle. That's it. All in that implant. Biggest is the UK. They have 2.1. The US is bigger. They have, I think, 2.6 million. But why is it but? The US registry has a completeness of not 99%, but of 39%. So 60%, so it's garbage in, garbage out. Forget big numbers. Look at completeness. Next slide. That's, well, is it ideal orthopedics? It is not. There's some research we did in the Core MD consortium. I was also in the steering board of this. That's from Anna Lübeck from Geneva, and I was also part, of course. We looked at the systematic review, and then next slide. It's just a summary. We looked at all these hips and knees only, and we saw there was no clinical study available. We did a random selection of these implants for CE marking, and even after that, not. And then 27% of all the implants in that review was nothing published. So things can be improved. And there were no RCTs. Well, that's the difficult thing in hips. You can have no hip, but next slide. Again, next slide, and next slide, next slide. So I'd like to share with you one opinion about evidence, what we do. Next slide. So this one, you can look it up on the website. I can't give you which company it was, but we evaluated a bone cement to fix a hip or knee or elbow. And we said, well, the expert panel agrees with the notified body, so we have to evaluate the CEAR, the clinical assessment report from the industry, and we assess also the opinion of the notified body, independent in a certain format, within these 60 minus 21 days. And I did the second one as well, this is already 3 years ago. I got really depressed. I needed to take pills. I was really, how come? The evidence in this paper, it was a shoulder implant, that's the only thing I can say. There were 31,000 shoulder implants implanted in people across the globe. They show data of 743 patients. That's 2.3%, just calculated again. And of the 743, they had 40% loss of follow-up. So I got really depressed. How come? But the notified body said, this implant can be certified. I was shocked. Anyway, next slide. So what we also do for free, well, 450 for 2 days, for 900 euros, 450 euros. And of course, we have a co-rapporteur, times 4. But when you just calculate, there's nothing, of course. We give them also free advice, what they should do. Can you next slide, I just highlighted the things. Lots of follow-up. There were 5 articles were missing. I just looked at the data. I just went to PubMed very easy and said, hey, the 5 articles there, they're missing. How come? We shouldn't have to do this, but I like to just, I was really intrigued because I also knew the 2 experts who advise the industry. I happen to know a lot of people in Europe. And these are nice guys. Perhaps women should have been better, I think. But anyway, that's really bad. How can this... But that industry also, when you have 31,000 and you give 741 in that report, and it was, I think, something like 1.4 gigabyte. But 80 pages are just how to implant a shoulder implant. Well, that's very fast for me. Anyway, so we can learn a lot. Next slide. So is that because the industry are the bad guys? Is it about trust? It's more about uncertainty, I think, because it's very difficult for them how to get this certification, I think. So the longer I work in this environment, 3 years ago I thought, hey, what's a bad thing? But I think everybody means well. The industry doesn't like to have a bad product. The regulators want to have a good product. The notified body also. And also you have also doctors who think, I do this, Rob, in my hands it works. Okay, but that might be because you are a nice guy or a nice woman. So we need evidence. So next slide. That's the reason we with the EMA, and that's a good thing. People could ask us free advice, next slide, on what kind of research should we do to have certification. There was one industry who came to us that wanted to have a new knee implant on the market. That's also amazing. They were advised by the industry. They were advised by a clinician, I think an orthopedic surgeon. They said we were going to do 50 total knees. We only ask them prompts. And then we do meaningful, I'm not joking now, meaningful statistics. So I asked the CEO of that company, what do you mean with meaningful statistics? I mean, I'm not joking. That was the advice of some expert. He probably gets 450 euros an hour, I think. And so the good thing is that with this pilot, I'm very happy with this. That we can prevent the industry from doing nonsense research. Next slide. So that's a slide that's now published by the EMA. See, especially Orthopaedics, we had about 12 free consultations. I think that's a good thing. I remember that when I talked to Paul Piscoy about this, Paul said, well, Rob, that's a bad thing. They should know what they should do. It's like, no, they're unaware. And even Paul is, I think, now convinced that that's a good thing, this pilot. And that will be, hopefully will be implemented, I think. Just to help the industry, help the system. That's all issue. Next slide. So what's the role? Well, we can give preclinical advice, like the recent pilot. Hopefully that will be implemented. We have the orphan designation. That's now also for orphan devices. There will be a panel. I think it's good to also have the people from orthopedics and cardiovascular, etc., also involved in this. I think I was a little against a separate orphan panel. I think orthopedic and trauma, and we have load-bearing joints, non-load-bearing joints, and spine. That's within my panel. Saying I have also some idea about the children, of course, because anyway. Next slide. So in the end, it's hopefully that we have a safe implants which have good performance for our patients. And this HTA perspective is very important, of course. I think that's nice that you also, and hopefully we work together. It's not that we have now this diversity, but Maya already said we have to work together. I have some progress. So what we did, some medical, but there will be a new guidance document. I think will be out 2025 on guidance on clinical evidence, but it's now 95 pages. I already told Paul Piscoy, that it's more like political science than real science. But that's too much, of course. And anyway, next slide. Core MD, next slide. And of course, Biomedical Alliance. Yeah, that's the last slide because we got in German. I thought it was nice to put a German slide in. That's from, they don't know who they did, anonymous, but Ludwig von Wittgenstein, a German philosopher, said, is it a duck or is it a rabbit? Kaninchen or ente? So what do you see? But we can have also a discussion on this, because when you do not know what a duck is or a rabbit, so when you are just a baby, without ever seeing a duck, then this might be a very interesting image. Now, that's probably a more philosophical remark I'm going to make, because the thing we see a duck or a rabbit has also to do with the background we have. So it's more like the perspective we have, stakeholder, regulator, surgeon, not everybody. This will, bring the world together, hopefully. That was what I'd like to share with you. Thank you.
Thanks very much, Rob. Any immediate question?
Is it a rabbit?
Is it indifferent?